So.
Okay, welcome Ken. So we're obviously about to do the oral scenario. Just to let you know that the way it will work is I'll just give you a brief call, the call that you've been called to, and then we'll talk about that. And then I've got some paperwork and some photos and things here, and we can just sort of give you a bit more information as we go. But just, it's about just talking through what you would do if you were actually attending this trial. And I just encourage you to ask questions. If you're not sure about things, just ask questions. I'll be asking some questions as well. Should take about 15 minutes.
It's okay if I've got my pad just to jot down notes?
Yep. So fine to take notes, and fine if you want me to read things or clarify anything that's not clear.
And I've also got the decision-making model to refer to. You're happy with that?
Yep. So let's start with just the call. So you're crewed with a BLS EMT, qualified paramedic. And you're called to an address in South Karori. It's 11:30 in the evening, and it's a winter's evening, and you're called to an elderly man in his 70s with acute onset shortness of breath.
Acute. This will be cool. Okay then. So,
just to start off with, just talk me through the kind of things you would be thinking about as you're responding to this job.
I'd be considering the worst en route as per the first strategy, and there are some things that I can probably immediately rule out, like croup or childhood diseases. But given that he's in his 70s, this could be there's a number of respiratory differentials like COPD. He could have acute pulmonary edema, could be a PE, could be having a cardiac event that's causing his shortness of breath, so it may not be a primary lung thing, so I'm going to put cardiac down broadly. And that could be an arrhythmia or an MI, or a less common thing. What else we got? Could be asthma. What would I be expecting? It's probably my main list to start with, and I'd just also keep an open mind that it was a non-respiratory thing in case the call was coded wrong.
Right.
Yeah.
Okay. Any thoughts as you're arriving at the house about what gear equipment that you would be taking in?
I tend to take everything in because I'm very cautious.
Okay.
Probably not suction and stuff like that unless the call was for an unconscious patient. And sorry, just another couple of things that have occurred to me. If it's, you say it was winter?
Yes.
And it's 11:30 p.m.
Yes.
So I should always have some sort of upper or lower respiratory infection.
Okay.
So just add them. Infection. I see a lot of them in winter.
Okay, I'm just going to give you a little bit of a sheet which just has some basic information about the scenario, and there is a picture on the back which is what you see when you walk into the bedroom and you take it.
Well, I see when I walk in. Okay, so there's a gentleman here who's on home oxygen by the look of it.
Yep.
Which immediately, I know my system one immediately jumps to either emphysema or lung cancer or something like that. So I kind of need to acknowledge that but not get too locked in. So those would be two things I'd immediately think of.
Right.
But I need to prove or disprove that that pattern recognition is correct.
Right.
So I've got crewed with an intern working at BLS level, address 11:30, 76-year-old. Severe respiratory distress. If he's severe, I know he's status 1. So we're thinking about backup and urgent action, any urgent action that needs to happen. He's sitting up in his bed, so that's suggestive that he's really symptomatic of this, and breathing very laboured, so that sort of fits with the severe respiratory distress. Wife called the ambulance because the shortness of breath seems to have suddenly got worse during the evening, so that's like a red flag for me as well, rather than a gradual decline. It's a sudden decline. She says he's been in bed all day and he's been feeling off colour and lacking in energy. So that sounds, first impression is that sounds like some sort of infection. But I know also that an infection like pneumonia or chest infection can kick off COPD or asthma or acute pulmonary edema. So I'll be looking for at least one thing, maybe more than one. Lacking in energy, she says he only saw the doctor 2 days ago, so he's been unwell for a couple of days. He seems a little confused today, so if he's got a lowered LOC and it's secondary to a respiratory cause, I'm very concerned. You observe that he's able to speak 1 to 2 words per breath, so those are red flags for me as well, which confirms, the information that he's severe, and therefore he's status 1. On auscultation of his lungs, you notice minimal lung sound, so not much air entry in all fields. Marked in drawing, extremely anxious and restless, so on the respiratory status assessment, these are all in the severe to life-threatening category. You note here's a spacer device and a peak flow meter by him as well as an oxygen cylinder and nasal prongs. So those all fit. Some of those fit with asthma, but actually they all fit with COPD, especially given his age, and the HOMO too, because not very many asthmatics, they're fine between attacks. So he's a smoker, fits with the COPD, he's long-standing history of hypertension, has had a recent MI, and is also a court patient. Okay, easy. Right, so first of all, I think I've got some urgent things to attend to, so I'd be... to me, he is big sick, so I'd be using, just to start off with, I'd be using this side of the decision-making model, because I think there's some urgent treatment I need to do before I get into any definitive diagnoses. I'd like to get his SATs, and that will determine whether I'm going to give oxygen. So do we have an SpO2?
Yeah, so he's got a saturations of 86%.
86, so... yes, I will start off with high flow oxygen via a non-rebreather, aiming for, at this stage, just sats between 88 and 92, just until I get a bit more info. Can I hear any abnormal lung sounds when I auscultate? Maybe there's not much air entry, but is there any abnormal sounds?
You can hear a barely audible wheeze in both sides, both lungs.
If there's a bilateral wheeze, it's suggestive of a widespread problem, like bronchoconstriction secondary to asthma or COPD, rather than like a pneumonia, one-sided. So yeah, I might get somebody to set up a neb of 5 milligrams salbutamol and 0.5 milligrams ipratropium, and run that. And I would just ask him, look, sir, do you have got COPD or CORD?
Yep.
Does this feel like one of your cord? Is it emphysema that you have?
And he nods to that.
Just yes or no. You have emphysema, and does this feel just like your other emphysema attacks, or does it
sort of goes maybe?
Maybe. Okay then. So in the short term, I think I'd still like to. Oh, okay. Can I hear any other sounds, abnormal sounds on auscultation?
No.
And I'm specifically thinking about crackles. I'll be listening low down in particular.
Yeah, and no, you don't hear anything.
No crackles. And very quickly, I'm just going to check his ankles. Is there any pedal edema evident?
No.
No pedal edema. So I'm just, this point, trying to rule out pulmonary edema as a possible differential, so that I can more confidently go down the bronchodilator route. You don't have asthma, sir? Never been?
No.
No. Okay then. And do you normally have salbutamol
And
at home.
Mine's yes, and his
Yes.
wife who's there also says yes.
And have you tried that this evening?
Yeah, lots.
Lots.
Absolutely.
Did it have any effect?
Not really.
Not really. So it's another red flag that home med's not working. And yours is oxygen driven or air driven?
Oxygen driven. Sorry, no, air driven.
Air driven.
Yeah.
Right. Well, what I'm thinking is I'd quite like to swap our high flow mask for a neb. It's the same stuff that you have. I'm not sure if you've got the ipratropium. We can look through his meds to check, but with the oxygen driven, I think it'll help where your own one may not have. So in the meantime, we'll start on the neb. Anything else urgent? So with my initial thing of COPD, if this doesn't improve relatively rapidly, I'm going to be thinking about calling an ICP for an adrenaline infusion and magnesium, IV magnesium. In fact, I think he's status 1. I'm going to call for that assistance to get them rolling towards me. I would also like, now that I've sort of done some initial urgent vent-driven treatment, to maybe move to the ambulance and start moving towards hospital, because I think he's critically ill. So get him stabilised in the ambulance, and now I can sort of start investigating whether there's anything else going on. So he's had a recent MI. I would like to just investigate a cardiac cause. What else did I have on my list of differentials here? COPD seems very likely. APO seems less likely. I'd like to get a blood pressure just to see if he's really hypertensive, which fits with APO.
Okay, so I can give you a set of vital signs, and the blood pressure is there.
Okay. So he has a pulse rate of 150. It's full. It's irregular. So I'd like to get an ECG on and check whether that's just ectopics or whether it's AF or something. Rest rate of 30 a minute, laboured, barely audible wheeze. LOC is 15. Sorry, his GCS is 15. Pupils equal and brisk response to light. His blood pressure is 110 on 90. So that doesn't sound like, doesn't fit with classic pulmonary edema. So it demotes that differential a little. His blood pressure is actually low for a 76-year-old, plus the pulse pressure is narrowed. So I'll just mark that as an anomaly and wonder what it means. His initial sats were 86. How are they improving with the treatment?
Up to 88.
Up to 88. And if I went through this respiratory status, his worker breathing still looks high? Is he still anxious?
Yes.
If I have another listen, do I detect any more air entry? Is the wheeze got a bit louder?
Slightly more.
Slightly
Entry
more.
and the wheeze is slightly louder.
And if I have a listen at the bases again, any new abnormal sounds? No. Okay, then so anything else I need to do for that? His skin colour.
Yeah.
What is his skin colour? It's pink, warm and clammy.
Clammy has a quite marked diaphoresis.
Okay then. And his BM, so his blood glucose measurement, is 5.1,
Yep.
and his temp is 38.5. Okay. Right, so I'm going to start investigating some of these other things. Infection seems like a likely cause. Sir, have you been coughing up any phlegm in the last couple of days?
No coughing, no phlegm.
No coughing up phlegm.
No.
If you had anything else, like you saw the doctor a couple of days ago, what was that for?
Oh yeah, he had a mole, some minor surgery, a mole taken off his leg.
Yep.
Yeah.
Okay then.
That was 2 days ago.
And have you been feeling hot and cold over the last couple of days?
Been sort of feeling both hot and then cold,
Right.
especially the day before, yesterday.
Day before yesterday?
And getting worse today. Bit shivery, but really hot, really cold.
Okay then. And if we do a 12 lead, just because I'm keen to see whether this is an MI contributing to any of this.
So 12 lead comes back as AF at a rate of 150.
AF 150, no ischemic changes, no ST elevation anywhere. Okay, fabulous. Right. So I'm also wondering whether his low-ish blood pressure, narrow pulse pressure, tachycardia and atrial fibrillation, which I understand is characteristic of sepsis, whether he has actually got sepsis. He's normally hypertensive, so I'm wondering about his blood pressure of 110 being hypotensive for him. His temperature is 38.5, but I can't hear any crackles in his lungs, which would be consistent with sepsis or septic shock. So yeah, I'm starting to think that maybe he has at least sepsis and possibly septic shock, in which case I would like to give him some fluid cautiously, but I just have to be careful here because he's 76, just had an MI and so on. Are there any sort of signs of dehydration, like is his skin tenting?
Quite a bit of tenting in the skin.
Tenting, if I get him to poke his tongue out, is it a bit dry and furry?
Yes, yes it does.
Okay then, so yes, I think I would call for, would suggest to my backup that we might run some fluid as per the septic shock protocol,
Okay.
and see how that goes, whether that improves the shock, and if that doesn't rapidly improve his perfusion, we can think about the antibiotics.
Okay.
Okay.